Hi everyone, Assalamu alaikum, and welcome to another episode of ECREM Talks, a podcast where we discuss emergency medicine core concepts and the impact of the specialty in the UAE. I am your host, Mohammed Jabr, and today we are going to talk about arterial and venous blood gases in an episode entitled ABG versus VBG. Blood gas testing is a very common and easy bedside test that gives you a lot of information, helping to direct your management. With VBG being the most commonly used in the emergency department, of course, as it is easier, it always creates dilemma with the other department on-call physicians. I'm sure most, if not all of you, have encountered this guy who says, I cannot trust VBG, do an ABG for me. But does it really matter? How much is the difference? When do we need to do an ABG in the emergency department? So let me introduce my co-host for today's episode, Dr. Ibraheem Al Zaabi. Ibrahim was my university classmate, roommate, and now he's a senior resident in SSMC Emergency Medicine residency program with me. Hi, Ibrahim.
Hi, Mohammed. Oh man, you reminded me of good old days.
Oh, it was really a good day.
I agree. Thanks for having me with you here today, and it's my pleasure to be part of ECREM Talks.
Yeah, working with you, Ibrahim, for a long time, I know that you had many conflicts with other specialties regarding the need of ABGs.
Yes, exactly, but not as many as yours. I think now it became a daily event, and that's why I'm interested in this topic to discuss the actual need of the ABG in the emergency department.
Then without further ado, let's dive in. Okay, let us start from what is ABG and VBG. ABG stands for arterial blood gases, which is a blood sample taken directly from an artery used to measure the metabolic environment, oxygenation, and ventilation status. Values such as pH, PCO2, PO2, bicarbonate, and base excess obtained by ABG are considered the gold standard. While VBG stands for venous blood gases, which is a blood sample taken from either peripheral or central veins, can serve as an alternative to an ABG when evaluating patients with metabolic and respiratory disturbances. Historically, values obtained by VBG have been criticized for a lack of accuracy in all domains. However, VBGs carries less risk of vascular injury, nerve damage, and cause much less pain to the patient. We will be discussing all these topics with the latest evidence. So my question to you, Ibrahim, imagine that you are working and your attending physician bring you the paper asking, what does this blood gas shows?
So, what does the blood gas shows? It seems like a simple question, but to me it feels like a trap, especially when the patient is critical and you want to get it right. Blood gas analysis is one of the useful tools or point of care investigation done in the emergency department, as you will get your results within minutes and can be helpful in direction of the management, especially during resuscitation. So what does it contain? It contains the following: acid-base balance and its component parts, partial pressure of oxygen, carbon dioxide, and oxygen saturation, several other anions and cations influenced by renal function, hemoglobin, hematocrit, and carboxyhemoglobin, glucose, and in the end, lactate.
Oh, that's too much information for a single test, making us emergency physicians wanting to do it for all of our patients. But what are the true emergency indications for a blood gas?
So, what is the indication? To keep it simple, I would like to think all critically ill patients will require blood gas. To dissect more, any patient who has an unexpected or inappropriate hypoxemia, with oxygen saturation being less than 94% in patients breathing in room air or requiring oxygen. Any deterioration in oxygen saturation or increasing shortness of breath in patient with previously stable hypoxemia, for example COPD. Any patient with risk factors for hypercapnic respiratory failure who develops acute shortness of breath, deterioration of oxygen saturation, drowsiness, or other symptoms of carbon dioxide retention, and for example, COPD or neuromuscular disorders. Severe metabolic disturbances, which includes the following: diabetes ketoacidosis or DKA, renal failure, hypothermia, severe sepsis, shock, or altered mental state.
Yeah, I agree with you, Ibrahim. And I will add to that acutely breathless patients with poor peripheral circulation in whom a reliable oximetry cannot be obtained, and patients with smoke inhalation suspecting carbon monoxide poisoning or cyanide poisoning. And please don't forget any previously stable patient who deteriorates and requires a significantly increased FiO2 to maintain a constant oxygen saturation.
So we know many people are advocating for doing ABG rather than VBG in critically ill patients. So Mohammed, what do you think the advantages and disadvantages of attaining ABG?
I do understand the point of view of the people asking for ABG, as it is considered the gold standard test for determining the arterial metabolic status. And it can also help determining the PO2. But the more important question that you raised, Ibrahim, is what are the disadvantages? You know, critically ill patients usually require serial testing, and thus it increases the risk of many things, including bleeding and hematoma, risk of pseudoaneurysm and AV fistula, risk of infection and nerve injury. It also increases the risk of needle stick injuries for the caregiver. It can also cause a delay of care, and it's a very painful and uncomfortable procedure. Have you ever underwent ABG yourself?
No, and I hope not.
Well, I personally did, and honestly, that's something I don't want to experience again. Yeah, I forgot to mention that pH, PCO2, and bicarb from a VBG are usually adequate for clinical decision making. So let's discuss the evidence behind that. So I will start with the first study that was published in Emergency Medicine Journal in 2001. It was a comparative study entitled Venous pH Can Safely Replace Arterial pH in the Initial Evaluation of Patients in the Emergency Department. So this study aimed to determine the extent of correlation of arterial and venous pH with a view to identify whether venous samples can be used as an alternative to arterial values in the clinical management of selected patients in the emergency department. It was a prospective study that included 246 patients. 196 of them had acute respiratory disease, while 50 had a suspected metabolic derangement. Well, the result was that the value of pH on arterial and venous sample were highly correlated, with an average difference between the sample of minus 0.4 units. And there was also a high level of agreement between the methods, with the 95% limit of agreement being minus 0.11 to plus 0.04 units. So they concluded that venous pH estimation shows a high degree of correlation and agreement with the arterial value, with acceptably narrow 95% limits of agreement. So venous pH estimation is an acceptable substitute for arterial measurement and may reduce risks of complications both for patients and healthcare workers.
Next, we'll talk about an interesting article: venous versus arterial blood gas in the assessment of patients presenting with an exacerbation of acute COPD. This was published in the American Journal of Emergency Medicine in 2012. Their clinical question was how to investigate the clinical correlation between VBG and ABG samples. They included 94 patients, and their results showed all causes of arterial hypercarbia were detected using VBG when a screening cutoff of 45 mm of mercury with sensitivity of 100%. The results showed venous pH and bicarb values have an excellent correlation with arterial values as well. In the conclusion, VBG can be used in the early assessment with good clinical decision-making tool. But still, do the difference between ABG and VBG actually change the clinical practice? We have another two studies. The first one is a prospective cohort study of 156 critically ill patients in the ED and ICU setting, and it was to evaluate the correlation between pH and PeCO2 when derived from ABG versus VBG, and it showed a good correlation between venous blood gas sampling and arterial sampling. Another study was done as a meta-analysis of 1,768 patients from 18 individual studies and found that the peripheral VBG correlates well with ABG in respect to the pH. So next we'll talk about the VNR trial, VBG versus ABG. But the context now is different. Now we'll talk about the pain assessment in taking the sample of ABG versus VBG. This is the first study done in a multi-center randomized control trial. It was published in the Emergency Medicine Journal in 2020. The primary outcome was to assess the maximal pain during sampling using a visual analog scale ranging from 0 to 100. The secondary outcome was to see the ease of sampling from easy to very difficult and the physician satisfaction. They included 113 patients, but these patients were non-hypoxic patients. And the results showed the mean maximal pain between the ABG and VBG range of 17.9. In the ABG group, the pain scale was 40. In the VBG group, the pain scale was 22. In the secondary outcomes, the first attempt success was more in the VBG group with a percentage of 91 comparing to the ABG group of 80%. The physician satisfaction was almost the same between the VBG and ABG, ranging between 97 to 95%.
So what are the differences by numbers? There is a nice summary card of VBG to ABG correlation found in LEM website, where they did a literature review from various studies and showed the following. pH correlation within 0.03 to 0.04 units. PCO2 correlation with a mean difference of -4. It was also found that PCO2 is 100% sensitive in detecting arterial hypercapnia using cutoff of 45 millimeter mercury, as Ibrahim mentioned earlier, but it may be non-correlative in severe shock cases. Bicarbonate correlation with mean difference of 0.52 and lactate correlation with mean difference of 0.08. So in conclusion, VBG has an overall good correlation with ABG, yet you may need to do an ABG for some selected cases. What are these cases?
That's a good question to ask, Mohammed. ABG may be necessary in the following situations. If you are concerned about hypoxia, for example, as in current pandemic of COVID-19, to accurately determine the PCO2 in severe shock, and finally, to accurately determine the PCO2 in hypercapnia.
So let's wrap this up. Thank you, Ibrahim, for joining me in this podcast. Do you have any final message?
Thank you, Mohammed, for having me in this episode. My take-home points will be: do more VBGs and less ABGs. There are very few cases when an ABG is clinically necessary, as we discussed earlier. But if you have an arterial line, go nuts with the ABGs.
That about ends this episode of ECREM Talks. Stay tuned for the next episode. Until then, this is ECREM Talks signing off.